All right, everybody, welcome back to the pre-hospital case study of Grander for February 2015. I'm very excited. Took a little holiday break, but glad to be back with you guys. If this is your first time watching any of these blogs, or I guess video lessons, more like it. My name is James Lutowski. I'm a paramedic and crew chief at the City of Pittsburgh EMS, and I'm also the assistant chief of Ingram Ambulance here in Pittsburgh. And I have been I've been a paramedic for almost 10 years now, coming up on 10 years this spring. Uh, so without any further ado, this month we're going to be talking about lead aVR, and it's going to come in two videos. Today we're going to talk about acute coronary findings in EKGs with aVR changes, and then we're going to talk about some other in a supplemental video that will be shorter later in the month about other uses for lead aVR. So one of the importance, one of the, why talking about aVR is so important is that a lot of times it's completely ignored. So when I was in paramedic school, like I said, about 10 years ago, we had instructors that we talk about the lateral leads and what vessels was associated with that, and the inferior leads and what vessel was associated with that. And when you would ask, well, what's aVR there for? It would be like those people themselves, our instructors, were not really that familiar with aVR, its uses, and how important the aVR could actually be. And so some of the things that we were told when we were in class was aVR, R stands for reciprocal. It's just the opposite of another lead. Or the aVR is there for a machine to calibrate itself, but has no clinical significance. And what we found is that obviously aVR has a lot of clinical significance and has the potential to save lives. So without any further ado, we're going to get started here. So first, I want you to think about, what do you know about aVR? What does it do? Where is it at on an EKG? What are its uses? What can it tell you about a patient? And if you're sitting there thinking, you're like tapping yourself on the head and you're doodling on your notepad and you're thinking, I just don't think there is anything about aVR that's important, then I would turn and look at you and I would say, you fool. Because clearly, number one, this is an aVR video. It's all about aVR, so there has to be something that it's important about. And number two, clinically significant research has come out that have shown the association with lead aVR and using it for diagnostic purposes can lead to improved outcomes in patients. So, shame on you if you were able to leave your page blank and not be able to think of anything about aVR that was worth talking about. So one of the things that you have to do, we're just going to start at the basics. So this is just a regular 12-lead EKG. Obviously, it's a blank one, but it is just a regular 12-lead EKG. And just to save you some heartache in case you're confused, I want you to look at this and tell me what lead. So this is lead 1. And I want you to think about where all the other leads are. Where's 2, 3, where's the V leads, where's the augmented leads, and I want you to kind of jot them down on a piece of paper, push pause, and then just kind of jot them down on a piece of paper. Nothing has to be fancy or artwork. You're not turning it in. I just want you to be able to visualize yourself, test your knowledge as to where all the leads are on the EKG. Now, if you're an advanced EMT or higher, advanced EMT that has 12 lead training, or a paramedic or higher than that, and you can't, on your piece of paper, write down where all the different leads would show up on the 12 lead EKG, then you should roll up your 12 lead cables, pack away your electrodes, and never do another 12 lead EKG again. Because if you can't even evaluate the basics, then you certainly shouldn't be using them for any diagnostic purposes on a real patient. So here's clearly just a standard 12 lead EKG. This is where the sections would be. So now, on that piece of paper that you wrote all the leads down on, I want you to associate what region of the heart is with each one of those leads. So for instance, I'll give you the hint that lead 1 is lateral. So fill in the rest of the boxes and push pause, take a second, fill in the rest of the boxes on what region of the heart is affected by which one of those leads. And then when you're back from pressing pause and doing exactly what I told you, which I know almost none of you did, you'll see that this is the diagram. You have the lateral leads, which are first and last. is what I always say of the lateral leads, first and last. The inferior ones are the ones that everybody seems to remember, and the septal anterior lateral leads out here. But what's also important is if you're doing a 12-lead EKG, you should know what region of the heart is associated with each lead, and you should also know what vessels are associated with that region of the heart. So that's a little bit trickier, but it's information that you should know. If you're performing EKGs and doing any diagnostic cardiac testing, you should know which vessels are associated with which part of the heart, which are associated with which leads. So push pause again right now, and I want you to fill in which vessels that you think are associated with which part of the heart. And then obviously when you come back, I'll show you that the lateral leads has a circumflex. The LED is the septal, anterior, and the laterals out in V5 and V6. And the RCA, right coronary artery, R2, 3, and AVF, the inferior leads. Now, here's what I was talking about. We have all this information to help us with diagnosing a patient, but then we look at lead aVR, and it's always this blank, lonely box. Nothing's filled in there. Nobody knows what to do with it. It's like that cousin that nobody's talked to in a couple years, and nobody wants to invite him to Christmas because he's just not like the rest of you, and he's kind of the black sheep, as you just kind of ignore him, even if he's there, and you just try to grin and bear it and not talk to him. So that's lead aVR, the black sheep of the family. But what we're talking about here today is the very significant importance of lead aVR. So what is aVR good for? It can help in predicting acute coronary syndrome when you have triple vessel or multiple vessel disease or acute LMCA, left main coronary artery, or a left anterior descending artery occlusion. And it can also help you with diagnosing a patient with pericarditis. And now these are the two that we're going to talk about today here on this video. In the supplemental video, we're going to go over some other reasons the aVR is important and some things that people are investigating to try to associate aVR with other things like diagnosing acute pulmonary embolism. Is definitely good use for axis determination, which can sometimes help you determine whether the patient's wide complex tachycardia is VTach or some other type of aberrant rhythm. And there's even some investigators trying to prove a relationship between the likelihood of having a seizure when you've had a tricyclic antidepressant overdose. So there will be a supplemental brief video that will come out later in the month of February. So when you're talking acute coronary syndrome in an aVR sense, what good is aVR? You need to first note that you'll have this acute ischemia, and almost every lead you'll have ST depression. Okay, the ST segment will be down below the baseline. You'll have ST elevation in lead aVR. Now, it's important to note that it doesn't have to be 1 millimeter of elevation in lead aVR, like it has to be in all the other leads to diagnose STEMI. In aVR, there's evidence that shows it just has to be greater or equal to half, 0.5 millimeters. And you can also have ST elevation in lead V1. So, and then another interesting little side fact is if you have ST elevation in aVR, you also have ST elevation in lead V1, and the ST elevation in aVR is greater than the ST elevation in V1, then it is highly sensitive and specific, about 80% both sensitive and specific to acute left main coronary artery lesion. So I got this picture from Wikipedia because I can't draw that good, but you'll get to see some of my fancy artwork here in a minute. This came from Wikipedia, and Patrick Lynch, I believe, was the artist. So I just want to give him a quick shout out. And I'm going to change my pen color because everything on this is red. So one of the things that we're talking about a lot is this left main coronary artery here, and this left anterior descending artery over here. And that is where these acute occlusions that are causing these profound diffuse ST elevations, that's where the proximal left main occlusion or the proximal LAD occlusion will cause that almost global ST ischemia. So if you imagine that you have an occlusion, this is my version of a plaque blocking the artery. So you have a lesion here in the left main artery. And let's just say that's 100% occluded. You're going to develop this dusky, cyanotic, ischemic part of the heart where just not a lot of oxygen is reaching those distal parts of those arteries, causing the heart muscle to become ischemic. And you can see that is such a large surface area fed by all those main coronary arteries that are coming right off of the left main artery that feeds such a large surface area of the heart and the heart muscle. Now, even worse is when you think about someone who has multi or triple vessel disease. When you have those lesions and you're looking at it, and you have over here in the right coronary artery blocked, you have the left main coronary artery blocked, you have the left anterior descending blocked, especially at a proximal close to the branch off of the left main. Proximal LAD, the more proximal, the more likely that you'll have these EKG findings. And the left circumflex blocked. All these vessels are blocked. So imagine if you thought that in the last image that I showed you had a large surface area and you were going to have some global ST ischemia just by having that left main coronary artery blocked, and it was blocking all of these over here. You know, all these vessels over here weren't getting any blood. So imagine now if you include all of these vessels fed by the right coronary artery. So the whole entire heart on the front is ischemic, and none of those tissues are receiving the correct amount of oxygen to function properly. So our 12-lead EKG, the standard 12-lead EKG, this is what it's looking at. And the whole surface area of what our 12 leads look at is now ischemic and getting ST depression, which is why you see that ST depression in almost every single lead except for aVR and lead V1. So this is an example of what you might see in a patient that's having an acute coronary syndrome with a triple vessel disease. You have the lateral ST depression, you have inferior ST depression, you have anterior and septal ST depression. The only leads that you're not having ST depression are aVR, and oftentimes you will have ST elevation also in V1. And remember, if the ST elevation in aVR is greater than the elevation in V1, it's more likely that is a very proximal LAD or a left main coronary artery occlusion. And if you have triple vessel disease, you have to throw in the right coronary artery, which is why you get the inferior wall ST depression. So we're going to go through some real life examples. One case worked perfectly, exactly like it should. The patient received cath lab intervention and a bypass surgery and did well. One patient didn't fare as well, and one patient passed away as a result of his coronary disease. So you have a 73-year-old male. He has chest pain and shortness of breath. We get to the dialysis center where he's at, and we find that he clearly has marked ST depression on his regular lead. But he's also tachycardic, which we'll talk about later, can sometimes mimic an ST elevation in aVR with ST depressions in all the other leads. So we decided to do 12-lead EKG. And clearly, in this 12-lead, you can see he's got some ST depression out here in 1, but global ST depression 2, 3, AVF, V2, V3, V4, 5, and 6, all with significant ST depression. And then in lead aVR, you have a profound amount of ST elevation, and you also have ST elevation in V1. And we just talked about if you have ST elevation in lead aVR that is greater than the ST elevation in lead V1, then that patient likely has a proximal LAD or left main coronary artery occlusion. One other interesting thing on this EKG is that this patient had intermittent right bundle branch block. And uh, what's so important about that is that a patient that there's some evidence to suggest a patient that is going into and out of a right bundle branch block, almost like a light bulb that's a little loose and flickering, and sometimes it's on and sometimes it's off, then that patient is at high risk for acute coronary syndrome. Um, and there's some investigators that are trying to link those two things, intermittent bundle branch block with acute coronary syndrome. And the reason that you can't see it out here, because normally in a right bundle branch block you would see a wide S wave, but the way the EKGs work is it takes the pictures leads at a time. So 1, 2, and 3 are taken at the same time. aVR, AVL, and AVF taken at the same time. 1, 2, and 3 in the V leads, and 4, 5, and 6 in the V leads are all taken at the same time. So when a 12 lead takes your picture of the heart, it goes at 1, 2, and 3 are taken first, then aVR, AVL, and AVF are taken second. V1, 2, and 3 are taken third, and then V4, 5, and 6 are taken fourth. And one way you can tell if something that happens in one of the leads is artifact or not is, let's say you looked here and you had, instead of that beat, you had this wide, bizarre complex. Whether that was a PVC or artifact, it's hard to say unless you look at the other leads. And because it didn't happen in AVL and AVF, it only happened in lead AVR. It had to be artifact because it was those pictures, AVR, AVL, and AVF, are taken at the same time, which shows you why you have the normal. I'll clear some of this jargon out of here. You have normal conduction in V1, 2, and 3, and then in all three of those leads, V1, 2, and 3, for 3 beats, you have the right bundle branch block pattern. And I just ran a strip of that because it was kind of interesting. And you can see here, those are those 3 beats, and you can see here's AVR with the rest of, it has that minimal ST elevation that's less than, V1 with minimal ST elevation that is less than the elevation in AVR. So this patient we saw him, we knew immediately that these look like ischemic T waves. He's having chest pain, he's having shortness of breath, he has a cardiac history. It's a high likelihood that this patient is having acute coronary syndrome, and this isn't rate related or any of the other mimics that we're going to talk about. So we did talk to our command physician, and we did activate the cath lab pre-hospitally. And the patient was found to have a 100% left main, diffuse LAD, 80% right coronary, and he received angioplasty and a CABG and was discharged to home in good health and spirits. So that was the last that we heard from that young man, and everything worked perfectly. We had a progressive command doctor, the receiving facility participated and didn't cancel the cath lab, and everything worked out perfectly for this man. Unfortunately, the next 2 cases end up a little differently. So this patient is a 61-year-old male who has chest pain and shortness of breath, and he had some angina problems in the past, but at rest it would go away. Tonight, a Saturday night, started in the evening around 6 or 7 p.m., and no matter what he did, rested, had ice water, cooled himself down, he could not get the chest pain and shortness of breath to relieve. He came home, it's around midnight, he was laying on the couch, he was too short of breath to go upstairs, he's having crushing chest pain. His wife finally says, we should call the ambulance. They did, and when my partner and I got there, he looked like a typical ST elevation MI type patient. He was sweating, he had crushing chest pain, he was very pale, short of breath visibly, and he kept saying that he thought he was going to die. And so we did the 12-lead EKG on him, and you can see here that we have the typical findings for a left main coronary artery or triple vessel disease or a proximal LAD occlusion. You have ST depression in 1, 2, 3, AVF, and out here in 4, 5, and 6. There might even be the starting of some elevation in V3. And AVL is pretty isoelectric. You have clear ST elevation in AVR, even though it's minimal, but remember, it only has to be 0.5 millimeter in AVR. And there, while not a lot of ST, you might have to imagine, maybe you're trying to imagine there's some ST elevation here. in lead V1. But if you notice, if you look closely, it does have straightening of the T wave. So instead of having a T wave that's kind of normal like that, it has a T wave that is straightening out. And that is one of the signs of an evolving ST elevation MI. So maybe there's no ST elevation in lead V1 at this time, but maybe it's developing. But we don't want you to imagine anything. It's clear there's elevation in aVR. There's ST depression that is global. So you look at this patient, he has all the symptoms. He looks like a cardiac patient. You consult medical command. Medical command says, yes, I think that's a STEMI. This patient's probably having a heart attack. It should be cath. It's the middle of the night on a Saturday night, so there's no cath team there, so it's better to get him to the hospital. So when we arrived at the emergency room, the attending physician had canceled the cath lab activation, consulted with cardiology, who agreed that it should be canceled. And eventually, the patient had a positive troponin. His chest pain worsened. He did get a cath on Monday morning, had triple vessel disease, and got a cabbage and was discharged home. The question is, does he have any permanent damage that could have been spared if he had received any catheterization or procedure on Saturday night as opposed to Monday morning? That answer will probably never be found out. And if you talk to a progressive cardiologist or progressive emergency room physician, they're going to say we should err on the side of the caution, probably should cath this guy. But the more conservative people are going to look at it and say this person didn't really have ST elevation and 2 or more contiguous leads. It wasn't 1 millimeter, and that's what the standards are. And they don't want to wake up the cardiologist for no reason to have them come in and do a negative cath, which I can understand. However, the times are changing. The science is supporting these findings and saying that it could be an acute coronary event that needs emergent PCI. So the next patient is the most unfortunate case. We have an 84-year-old male who's woke up with he ate dinner, had some mild chest pain, and a little bit of weakness. He took an antacid, did not feel better. Eventually, his wife said, it's Sunday evening, it's right after dinner, 5:30. He says, I'm not feeling too good, and the wife said we should call 911. So when we arrived at the patient, he looked okay. But you can see when we put him on just the 4 lead, there's profound ST depression. So he's also an AFib. So you think to yourself, maybe the patient's having rate related, but his rate really isn't that fast. It's right around 100. So we do the 12 lead EKG, and to no one's surprise that is watching this video class, he has ST depression in every single lead, and I'm talking every lead, except he has ST elevation in aVR. He has some slight ST elevation, maybe not, in lead V1. But if there's no ST elevation there, which you almost have to imagine it if it's there or not, it's pretty isoelectric in V1. It has that straightening of the T wave. So when you have that T wave that's starting to straighten out, that is more likely to be developing ST elevation than just having a regular concave type T wave. So this patient, like the others, we consulted with medical command. Medical command was kind of non-committal. They called the receiving facility, who the receiving facility denied cath lab activation, so they would evaluate the patient themselves. So this patient did not receive a pre-hospital cath lab activation around 5:30 p.m. on a Sunday night. So the patient's taken to the hospital at 5:30 p.m. We transported him. At around 7 p.m., he said, man, my chest pain is getting worse. They did another 12-lead EKG. He had ST elevation in aVR and V1 now, but definitely ST elevation as well in 2-3 and AVF. So they decided at 9:30 p.m., not 9:30. Yeah, at 9:30 p.m., they activated the cath lab after consulting with the cardiologist multiple times and doing serial EKGs and waiting for the blood work to come back, which had a positive troponin. The cath lab team arrived at about 10:15, took the patient up. He had triple vessel disease. They were preparing for emergent bypass surgery, but the patient suffered a cardiac arrest, and unfortunately, he did not make it. Now, the question that you have to ask yourself is that the patient started having chest pain at 5 p.m. At 5:30, an ambulance came to his house. We looked at him and said it's highly likely this patient is having an acute coronary emergency. Maybe we should send him to the cath lab. The powers that be denied that and said we'll evaluate him and decide his course of treatment when you arrive. At 7 p.m., an hour and a half later, he had worsened chest pain. But it wasn't until 21:30, 9:30 at night when the cath lab team was finally agreed to come in to see the patient. Now, if at 5:30 the cath lab was activated and the patient wasn't going upstairs almost at 10:30, would that 5 hours, if you were able to reperfuse his heart, would that 5 hours had made a difference in the patient's survivability? And the answer really is nobody will ever know. There's no way to tell if he had too bad of a atherosclerosis or coronary artery disease to survive it anyway, or if he just didn't tolerate the procedure well. It's unable. Nobody can ever say. It's just conjecture, and it's unfortunate that that patient didn't have that chance at least to have that procedure earlier, and instead had an MI for 5 hours more after the time that the ambulance originally got to his house. And so we'll talk about quickly the reason that nobody wants to activate the cath lab on these aVR elevation MIs is there's also aVR MI mimics, and it's imperative that as a clinician you can troubleshoot aVR ST elevation and then advocate for the patient based on what you truly believe it is. So we're not trying to activate the cath lab because we think it's cool or it's more fun or it makes our patients more serious, because truly a lot of patients that are seen in the ambulance, even though they're not in extremis, have true medical emergencies. So you don't need to send the patient for the cath lab if they have ST depression and elevation aVR for that to be a serious patient. By definition, if you have changes on EKG, that's a serious patient. So whether that ST elevation and aVR and the depression and all the other leads is caused by myocardial ischemia from a lesion, or if it's caused by severe tachycardia or pulmonary embolism preventing the exchange of oxygen, or there being no hemoglobin in the blood to deliver oxygen, it doesn't matter what the cause is, the patient needs to be treated for that cause. And unfortunately, if you were to send a patient to the cath lab when it turned out that the patient was bleeding with a GI bleed all night, and that's the reason that they had these ST segment changes, sending that person to the cath lab could actually be very detrimental to them. So some of the mimics we're going to talk about is the tachycardia, hypoxic events, either respiratory distress like COPD, or traumatic asphyxia, or pulmonary embolism, where the blood oxygen and carbon dioxide exchange cannot take place, or a severe iron deficiency like having a GI bleed or any type of anemia. So these two patients are rate related. The top one, you have a 62-year-old male with palpitations and shortness of breath, and the bottom you have a 74-year-old female with shortness of breath. You can see ST depressions in 1, 2, 3, AVF, V2, V3, maybe even a little up here in V1, and all the V4, V5, and 6 leads. You have ST elevation, lead aVR, and like I said, a little bit of depression in V1. And this patient was purely rate related. Once they were able to slow his rate, the EKG changes went back to normal. This patient on the bottom, 74-year-old female who had shortness of breath. You have some mild ST depressions in 2, 3, AVF. You have some up-sloping ST depression here in V2 and V3. You have some very mild or minimal ST depression out here in V4, 5, and 6 with ST elevation in aVR and straightening of the T wave in V1. Now, this patient also was suffering from rate-related ischemic changes This patient was not having an acute coronary syndrome. This patient, once they converted the rhythm, he went completely, or she went, excuse me, her EKG changes resolved. Here's another rate-related case, and this one looks very much like a severe acute coronary syndrome case with a proximal LAD or left main coronary artery. You have ST depression 1, 2, 3, AVF, out here, aVR, V2, V3, V4, 5, and 6, all have ST depression. You have elevation, pretty profound here in lead aVR. You also have elevation in lead V1. So this patient has all the earmarks of having proximal LAD or left main coronary artery. However, when you also got her history, which was the physician just recently decreased her dose of diltiazem daily, and that she has a history of rapid AFib, and the palpitations just started recently over the past couple of hours, you start down a different track of thought. And so in the ambulance, we decided the patient was having rapid AFib. We gave the patient 10 milligrams of cardizem, and after we gave the cardizem, the patient spontaneously converted, not spontaneously due to the cardizem obviously, converted to normal sinus rhythm. And before we even got to the emergency room, the ECG abnormalities were resolved. And you can compare these two EKGs here. Let me see if I can get rid of that junk. If you just compare the leads, you can see all those profound ST depressions gone. Maybe minimal, if any, ST depressions. This goes back to being a kind of a flat T. You have minimal, if any, ST elevation in aVR. So this EKG change was witnessed prior to the arrival at the emergency room. The City of Pittsburgh transport times are only about usually 5 to 15 minutes, and that is how quickly the heart responded as soon as it was able to get its oxygen back from, it was all out of breath from beating so hard and hitting that marathon. And then when it was able to slow down and take a rest, all those myocardial oxygen demands went away. The patient was receiving enough oxygen. The EKG abnormalities resolved themselves. This case is a different case, and I'm going to withhold part of the history from you because I don't want you to know everything. So let's just say you respond to a woman, 59-year-old female, she's dizzy. When we got there, she just said, I'm dizzy. I just don't feel good. I'm a little pale today, and I feel dizzy. So we do an EKG on her. You have mild ST depressions out here in 1, 2, and 3. You have some ST depression out here in AVF. You maybe have a little upslope in depression V2, more in V3, and out here in V4, 5, and 6 is clearly noticeable. No real ST elevation, if any, in lead V1, but you have a fair amount of ST elevation in lead aVR. So this patient kind of has the hallmarks of a left main coronary artery or proximal LAD occlusion. But what's a little different is this patient doesn't have any classic MI symptoms. And everyone knows that you can have an atypical MI where you just have shortness of breath or you just have nausea and vomiting. And that's all true. The most classic sign that's associated with most patients having an MI is chest pain and shortness of breath, nausea and vomiting, and diaphoresis. But once you pass beyond that group of symptoms, the patient could be complaining of dizziness, but without one of those other symptoms with it, it's a much less likelihood that the patient's having an acute coronary syndrome that's just causing dizziness. So because the patient doesn't have anything beyond dizziness, we got the rest of the story, which showed that the patient had a little bit of hypotension, that we gave her an IV and gave her some crystalloid, and she said she had been having vaginal bleeding for about 3 to 4 days. At the hospital, they found her hemoglobin to be 4.5, so she was severely anemic, and she got a transfusion in the emergency room, treated medically in the ICU. She was discharged to home with complete resolution of all the EKG changes. So here you have a patient who was actively bleeding, had severe anemia, and she has an EKG that could mimic the findings of a left main or proximal LAD occlusion. So what we're talking about here is how we don't want to jump to conclusions. Um, in this set of EKGs, this one is a STEMI. This one is rate related, and this one is the um, anemic patient. So you can see that they all have similar findings. And even though this one has ominous looking ST depression, as it turns out that the moment that you give that person cortisone, then those depressions resolve. Up here, this patient obviously requires PCI. Down here, the patient needs blood. All three of these patients desperately need the correct medical treatment. But it's not PCI for everybody. So it's very important to get a good history, get a good exam, and then use all of your puzzle pieces to make a big picture, as opposed to just jumping to conclusions. Because if we do 50 activations of the cath lab in the next 5 years for an aVR elevated MI, and 39 of those turn out to be false activations, and the cardiologists are not going to let us do any more aVR elevation MI activation. Um, so if we're trying to change the system and change the way that everybody's thinking and the cath lab activation protocol, we need to make sure that everybody's educated. And unfortunately, even if you're sure and you call your command physician, the command physician might not have exposure to this or this research, and they themselves might give you bad advice. So it's important for everybody in emergency medicine to kind of research on this, and hopefully in the near future we'll be able to get a study, retroactive study that looks at all these patients that we've had over the past X amount of years with ST elevation aVR and profound ST depression in the other leads, and what their outcomes were, and if there was anything acute found. So hopefully we can help set up the building blocks to decide if activating the cath lab should be standard for this type of patient with a certain history, or if it's not that many patients. But the one thing I want you to note is all these EKGs that I've showed you, the STEMI patients that had an aVR elevation MI, the one that got the cath lab activation and the two that didn't, those are my patients. I had those patients. All three patients that have the rate-related ST depression with aVR elevation, I had those patients. And the patient I had with the anemia with aVR elevation and ST depression globally, that was my patient. So I've worked at Pittsburgh EMS for less than 5 years, and I am the one who took all of these EKGs on these patients, which means this EKG finding is pretty significant, and the frequency of it is probably very high. And so we need to help work out if there's a way to differentiate the etiology of this specific EKG finding, and if we can differentiate, what we can do with that information and how can we better serve our patients is the most important thing to take away from this. So pay attention when you're doing these EKGs, and next time you do an EKG on someone, don't just say, oh, there's some ST depressions all over the place. aVR looks a little wonky, but we don't deal with that. Take a closer look when you see a lot of ST depression and try to differentiate between what the cause could be and evaluate it to see if the patient has an aVR elevation MI. Finally, I couldn't find any of my EKGs for this certain diagnosis, but push pause. I want you to look at it for a minute, decide what this EKG likely is, and of course you'll probably find out after you push pause and do it. And then when you come back, you'll find out that it's a pericarditis case. The patient has diffuse ST elevation. The elevations are all kind of concave, curved upwards. You can see that there's ST or PR depressions in all these leads, PR depressions. You also have spodic sign where the isoelectric line is pointing downwards. It's kind of on a downward slant. And there's no reciprocal changes. There's no T-wave inversion or ST depression in any of the leads except for lead aVR. And what we're going to talk about here is what's called knuckle sign. And the knuckle sign is when aVR is showing PR elevation instead of depression. You have PR elevation and then ST segment depression. And that PR elevation is what's called knuckle sign. So you have a 55-year-old male, fever, shortness of breath, and chest pain. As it turns out, he has acute pericarditis, is treated with antibiotics and an in-hospital admission. And here's just my beautiful artwork that I did for you guys, since I don't have any other real examples. It's just you have this PR elevation here, you have ST segment depression there, and you have this upward curved ST elevation and all of these other leads without any T wave inversion or ST depression except in lead aVR. So this patient diagnosed with pericarditis. So what I want you to take home from this, aVR has a variety of uses. It's very important, can predict acute coronary syndromes, could probably change the course of treatment and maybe even save a life on a patient that has an acute LMCA or proximal LAD occlusion or has acute exacerbation of triple or multiple vessel disease. It can help you with ruling in pericarditis. And remember, you have to advocate for your patients, but you have to be smart about it. You can't just say this patient has aVR elevation, and then when the physician says, I don't think we're going to activate the cath lab, if you don't have any more information on what the cause could be or any logical line of thought, then of course the physician is not going to back you up on cath lab activation. And you also have to be able to, before you call for that cath lab activation, rule out some of the other potential causes like bleeding or respiratory distress or extreme tachycardias. And maybe one day we'll get aVR to have its own inclusion on our little charts, and it really can help predict many parts of the heart and some ischemic changes, and it can also help predict with multiple different arteries because it's useful in that proximal LMCA and proximal LAD, and when there's elevation in aVR and V1, it can likely, with those profound depressions in the inferior leads, it can also have that right coronary artery involvement. So thank you everyone for spending your time with me this month in February. Remember, we're going to have a supplemental video that comes out with a little bit more about aVR later in the month. And remember to send me your good EKGs. Scan them in, take a picture of them with your iPhone, and email them to ekgsforjames@gmail.com. I want to keep building my library back up, and I can't do it without you guys' help. I can only do so many 12 EKGs myself out here in Pittsburgh, and so your help would be greatly appreciated. So thank you very much again, and until next time, I look forward to seeing you again.